Why can one twin develop sepsis, while the other remains normal, despite the same mother? Although twins share the same maternal environment, they do not share identical intrauterine, intrapartum, or immediate postnatal conditions. Sepsis depends on multiple fetal, placental, and delivery-related factors, which can differ between twins. Let's get started. The first factor is placental and membrane factors. Most important. Separate amniotic sacs, that means twins should be diamniotic twins. Infection may ascend into one amniotic sac only. So only one sac will be infected. So, only one twin exposed to infected liquor, while the other remains protected. This is very common in dichorionic diamniotic twins. Placental vascular differences. This matters if the babies share one placenta, meaning they are monochorionic twins. In twin pregnancies, particularly monochorionic twins, those sharing a single placenta. Placental vascular differences and localized inflammation, chorioamnionitis, create distinct environments for each fetus. Let's discuss them one by one. Unequal placental sharing. Unequal sharing occurs when the placenta is not divided evenly, often due to unpredictable umbilical cord insertion sites. This leads to selective growth restriction. The twin with the smaller placental share receives fewer nutrients and less oxygen, leading to selective fetal growth restriction. Localized chorioamnionitis. Inflammation of the placenta and fetal membranes, chorioamnionitis, may not affect the entire placenta uniformly. It can be localized to the specific placental territory of only one twin. The presenting twin effect. Because chorioamnionitis is often an ascending infection, the presenting twin, the one closest to the cervix, is typically exposed to a higher bacterial load and longer exposure to inflammatory mediators. The next factor is the order of delivery. In twin deliveries, the second twin, twin B, is often at a higher clinical risk for complications, including early-onset sepsis, due to several physiological and procedural factors. Prolonged rupture of membranes. Twin B often experiences a longer interval between the rupture of membranes and delivery compared to the first twin, increasing the window for potential infection. Delayed delivery exposes the second twin to maternal vaginal bacteria for a greater duration, which is a significant risk factor for ascending infections like early-onset sepsis. Increased duration of labor stress. The delivery of the first twin can lead to reduced utero-placental blood flow, compromising oxygen and nutritional supply to the second twin while it remains in utero. Greater need for manipulation. Twin B is more likely to require obstetric maneuvers, such as internal version, forceps, or breech extraction, to facilitate delivery, especially if it is in a non-vertex position. The third factor is differences in immune maturity. In twin pregnancies, immune maturity can vary significantly between siblings due to differences placental sharing. A smaller or growth-restricted twin often faces a disproportionately higher risk of early-onset sepsis, compared to their larger co-twin. Reduced immunoglobulin, IgG, transfer. Maternal IgG transfer is a critical third trimester process for passive immunity. Smaller twins, particularly in monochorionic pregnancies, sharing a placenta, often receive lower cord blood concentrations of IgG compared to larger or dichorionic twins. The last factor is invasive procedures done to one twin. While twins share the same maternal history, invasive procedures, like prolonged resuscitation, intubation or UVC insertion, can cause one twin to be at a higher risk of infection than the other, as these interventions directly introduce pathogens into the bloodstream. Therefore, same mother is not equal to same infection exposure in twins.